So a lot of patients coming in your clinic have all the symptoms then. I mean, your patients are the rhinitis patients because that's a lot of what you're seeing. So your job is really figuring out which tool to use for which patient because, you've got your nasal polyp patients and then you might have your purely rhinitis patients, I assume.
Or your CSF rhinorrhea patients.
Or your,
Right. Yeah. Or your allergic rhinitis patients. So there's lots of different types of rhinitis. And, it's important to figure out what the right thing is. So that involves, I kind of have a staged approach. I'll obviously talk to them, take a look at them, figure out if they have allergies or not. And then these patients get a nasal endoscopy. And that's a really, really important part of the workup for two reasons. One, to see if there's any nasal pathology, not only in the nasal cavity, but also the nasopharynx. And then the second is to see how their anatomy is. Do they have a super deviated septum or a very tight nose where you think, this is going to be really tough to do in clinic. I might have to take them to the operating room, or I might have to do a septoplasty along with it. And then the third reason to do the nasal endoscopy is to see how they tolerate it. If someone is super anxious and they're fighting your endoscopy, that's not a patient you want to do anything on in clinic, and they're just going to get to take a nice 10-minute nap in the operating room and do it from there. So that's the nasal endoscopy. If that looks good, then I'm going to want to get a CT scan. And the reason for the sinus CT scan, part of it stemmed from some of the first studies with the Neuromark device is the CT scan was required basically to rule out a sinus infection or inflammation. And what we found, there was about 15 to 20% of people who had just postnasal drainage had sinus inflammation, a lot of the times in the posterior ethmoids or the sphenoid sinuses. So that was a key thing to rule out sinus disease. And while I'm waiting to get the pre-authorization for the CT scan, I'll put them on a trial of ipratropium bromide spray. And that's been very, very helpful, not only to treat potentially their symptoms, but it also helps with the diagnosis. If it works, then you have a high likelihood that they have vasomotor rhinitis. And there's a cool study that was done that showed if the ipratropium spray helped, then there was an 85% success rate with any type of posterior nasal nerve ablation. Whereas if the ipratropium did not help, the success rate was down to about 33%.
So everyone gets a scan. Did your practice change after you realized that maybe 20% of normal scopes have something on their scan?
Yeah, so it's not in the IFU that you have to get a CT scan, so it's not a requirement. But I think it's part of good clinical practice. And again, there's several times where I've gotten a scan on an older patient and they've had chronic sphenoid sinus disease. You can tell because of the reactive osteitis of the sphenoid bone, and it's completely opacified. And without the scan, I would have missed that. I would have done a PNN ablation. They wouldn't have gotten better. And then I would have done a scan and had to open up their sphenoid sinus. So I do feel much better doing the scan up front.
How often do the patients that have a clean or nasal endoscopy, who have the rhinitis, who you get a scan on, have other CRS type symptoms? Like, are there other things that kind of also point towards, hey, there's probably sinusitis here? Or is the face pain, nasal obstruction, change in smell also part of those presentations, or not always?
Not always. And that's the humbling
That's hard.
thing. You'd think, especially after 18 years of doing this, I could talk to somebody and actually figure it out. But no, I get humbled all the time. And when you really dive into it, you would think a sphenoid opacification would have, pain on the vertex, or pain behind the eyes, definitely postnasal drainage, maybe some congestion, eustachian tube dysfunction. But a lot of times they're just, no, I have a runny nose. That's it.
And then I was going to ask for the ipratropium patients, do you find that it's as effective non-allergic rhinitis or allergic rhinitis patients as it is in your non-allergic rhinitis? Is it for all comers that if they're responsive to ipratropium, then there's that 85% success rate, or do those groups vary for you?
It's pretty equal. So the ipratropium is anticholinergic, so it really shouldn't do anything for allergies. And I also explain that to patients because a lot of the times they're already on Flonase or Astepro, and they're like, oh, I've done nasal sprays. I'm like, this one's specific, you haven't done it yet, trust me. It's a prescription only. And so they know if they keep doing whatever medicine they're doing. So I tell them, hey, don't change anything. I only want to change one variable. And we're going to add the ipratropium. And if that works, we know what you have. If it doesn't work, well, we can talk about what to do as a next step.
Got it. So if it's positive, if they do have a response to the ipratropium, then we feel good that it offering them like a PNN ablation, they're going to have a high chance of getting some improvement from that. But if they don't, it doesn't necessarily mean that they're not a candidate.
Yeah, it's very true. And I think so much of what we do, especially with elective procedures and elective surgery, is about setting expectations. And, it's one thing if insurance is covering it, but if insurance doesn't cover it and they're paying out of pocket for this procedure, it's really important to set the expectations appropriately.
So other medical management options, I assume you're probably talking to patients about allergy nasal sprays too, saline, all that kind of stuff. Anything else?
You nailed it. That's it. And most of the patients have already done that, right? We have nasal steroids, we have nasal antihistamines, oral antihistamines, saline irrigations. If someone does have a strong allergy history and they're really complaining of worse seasonal symptoms, then we're going to go down the allergy pathway, and I'll probably end up allergy testing them as well, which our practice does, and it's easy enough to do.